We're going to start off with our colleague Alison McCaig. So Alison is a consultant haematologist up at the Queen Elizabeth Hospital in Glasgow. She is, in fact, her day is basically full of CLL and lymphoma. Her name is well known, and also in Scotland, she's been involved with a lot of drug approvals, lymphoma, CLL. So we're delighted that she's going to be talking to us for the first half of this evening. We're going to concentrate on CLL biology initially. The format that's worked well before is a 40-minute lecture and then a 20-minute chat and discussion with panel members. We always encourage audience participation. So if you're a delegate listening in and you want to post your questions, you can do those in the chat. It'll help our discussions flow. So that's the first part of the evening. The second half of the evening, which Renata will be chairing, will bring in Lelia and John for a patient perspective, for a more detailed analysis of some more up-to-date survey data from the patient groups, and to explore the whole principle of how clinic consultations work optimally. But I'll be handing Renata that one to introduce in the second half.
Thank you again to everybody who is tuned in this evening, or if you are watching this on demand. So over the next 40 minutes, I'm going to take a run through and have been given the title to speak to this evening on what's new in basic biology in CLL. So what I'll try and do is start from the basics and then take it through towards the new and current science that is going to be shaping our future treatments. So hopefully a little bit for everybody this evening. So to do that, before we speak about CLL, I have to say a little bit about the amazing things that normal B lymphocytes get up to and do during their normal development in health to keep us well and free from infection and give us our immunity, so that we can understand a little bit more about what might happen when things go wrong. Then I will start to introduce the condition that we know of as CLL and speak a little bit about diagnosis and the investigations we do when we meet a new patient, and then go down and delve a bit more into the model of pathogenesis and biology, as I've been asked to speak on, and speak a little bit about what we now know as a precursor condition, monoclonal B-cell lymphocytosis, or MBL. And as you will see later in this programme next week, you'll hear a lot about our current therapies and how we use our current therapies, and a lot of data on treating CLL. What I'm going to do towards the end of the talk is speak a little bit about how we look after really a sizable percentage of our patients in clinic where we don't initially treat, and speak a bit about preventative and supportive care. So back to B lymphocytes. So B lymphocytes, as with all of our blood cells, will start off and develop from hematopoietic stem cells in the bone marrow. And then the first job of a B cell is to go through a process to make a kind of unique B-cell receptor or immunoglobulin molecule, and we'll speak a bit more about those processes. So that then equips a naive B cell with a B cell receptor that should be equipped to recognise some bug or virus or threat to the body. Once it does that, if it does encounter something it doesn't look like the look of, it will then go into a lymph node and go through quite a complicated process of trying to refine and make a better B cell receptor to then be able to exit that lymph node and affect the immune response and give us immune memory. So a little bit more detail on that. The first in the early steps of making a B cell, one of the first things that happens is that there are a number of genes called V, D, and J that the B cell can randomly or select to use a different combination in each B cell to form a unique B cell receptor. So the process of VDJ recombination is something that we'll come back to when we're speaking about what we observe in CLL. So once we have a B cell that's got its B cell receptor, if it comes into contact with an antigen for example, bacteria or something that could do us harm. It zips into the lymph node, and the colours are not quite accurate, but representative. And what will happen there is B cells are really specialised that actually at this point in their development, they can undergo proliferation and a process of additional mutation, what we call somatic hypermutation, with the idea of making a kind of loosely fitting antibody, a really tightly fitting, really effective antibody to recognise that whatever pathogen is coming in to attack us. So in that process, a lot of the cells will die off. So any ineffective antibodies or cells that could react to our own tissues should be killed off by a process called apoptosis, and only a few cells get out the other side as effector mature plasma cells or memory cells. Okay, so as B cells go through all of their stages of development, in almost the default position is for them to almost die off unless they receive certain signals at each stage to promote their survival and induce what we call anti-apoptosis or survival genes, including things called MCL1 or BCL2. So I should say a little bit more at this point about the BCL2 family proteins and apoptosis, and they control what happens in our mitochondria. So you may have heard of mitochondria as kind of batteries or controlling energy of a cell. The other thing that in their membranes, they're packed full of stuff that could, if it's released into the cell cytoplasm, trigger a cell to turn up its toes and go into cell death or apoptosis. So there are a number of different BCL2 family proteins, and they can be either on pro-survival or pro-apoptosis, pro-death sides. And what happens, they can bind to each other and antagonize each other. And really, it's almost like a tug of war, and whichever type of pro or anti-apoptotic protein is in excess could generally win and determine what happens to the cell. And many of you will obviously practicing in hematology will be familiar with them using BCL2 inhibitors in CLL, but we'll talk a little bit more about why that is. So I just wanted to introduce BCL2 family proteins and apoptosis at this point. So should move on to say a little bit about CLL. So we know that CLL is a leukemia, chronic leukemia that arises from B lymphocytes. There's no such thing as CLL. It's the most common of the hematological malignancy. It's the most common leukemia that we look after, and there's a slight male predominance, and like many of the hematological malignancies we look after, the incidence increases the longer we've had our bodies and our immune systems. So for CLL, the average age of diagnosis is somewhere in the 70s. However, I do have a number of patients in their 30s and 40s coming along to my clinic as well, so it can affect really anyone from mid to later life. We will speak a goodly bit more about what we now define as monoclonal B-cell lymphocytosis, which we now know can be a precursor condition, but by no means it does not but not all cases by a long way of MBL will develop into CLL, as we'll hear. We know that CLL is a very heterogeneous condition, and a number of the majority of patients, although it is a treatable condition, unfortunately at present, we do not, aside from a small number of patients, perhaps achieve a functional cure, and we don't always treat at diagnosis, and for many patients we manage with active surveillance. So how do we make it, and what might lead to a diagnosis of CLL? And currently, certainly the majority of our patients are now diagnosed incidentally on a blood count that's done for an entirely other reason, whether it's a diabetic annual review or preoperatively. We would diagnose the majority of our patients picking up an incidental lymphocytosis. However, for some people, we do are referred patients who are referred up with lymphadenopathy, perhaps with an enlarged spleen or hepatomegaly. B symptoms can occur, but they are less common in CLL and always make us stop to think as to whether there might be a higher grade transformation that we call Richter transformation. But B symptoms can occasionally occur with CLL. We know that the process of self-tolerance in terms of our immune system can be dysregulated with CLL, leading predominantly either to autoimmune red cell hemolysis or to immune thrombocytopenia. And we also know that the production of normal antibodies can be disrupted as well. We can see recurrent infections due to secondary hypergammaglobulinemia, which can be more common as in people with progressive or active CLL. So how do we make the diagnosis of CLL? And in the majority of cases, things are fairly straightforward, and the diagnostic requirements require a clonal B cell population of at least 5 times 10 to the 9 per litre in the peripheral blood, and we make the diagnosis generally on a characteristic immunophenotype that we see in flow cytometry with expression of CD5, 23 and low levels of CD20 and surface immunoglobulin. And you will read in, and may have read in textbooks, about a CLL score. We're looking at 5 markers, and that is called the Matut's score, where it's pretty good, and we've used it for many years, and the majority of patients with CLL will score between 3 and 5 on this. And if we have a low score, we need to think of other CD23 or CD5 positive malignancies such as marginal zone lymphoma or excluding mantle cell lymphoma. So that's been used for many years. I've been asked to speak about an update, and I wanted just to share a bit of new data and an update on how we make a diagnosis, because we know the Matut's score isn't perfect. We know that some people with CLL the cells might not express CD5, so the Matut's score might not capture all. Sometimes the diagnosis can be a little bit more tricky. So there has been a lot of work by a European group with an acronym ERIC, who have recently published a consensus document listing what they list as required antigens to have in a flow panel, and also recommended antigens, including things like CD200 and ROR1, which can be very helpful in difficult cases. And certainly our local lab has recently changed the flow panel to change from reporting a score to reporting just as to whether it is a phenotype compatible with CLL or whether it looks like another non-CLL B cell malignancy. So that's really a bit of an update in flow cytometry. The next slide I don't want to spend too much time on, but just to run through, by the end of this talk, you'll know a little bit more about immunoglobulin heavy chain IGHV mutation importance in CLL, and we can look for the presence of IGHV mutations, and that could be quite useful to do a diagnosis because it is fixed and doesn't change over time, unlike other genetic lesions that can change and be acquired over time, such as 17p or TP53 deletion, which we can see acquired over time. One thing I do want to say is in the majority of patients where we make a diagnosis of CLL, we don't tend to need to do terribly much more at diagnosis. We don't tend to need to do a lymph node biopsy or to do a bone marrow aspirate or trophine, unless there are unexplained cytopenias where it's not clear whether it's disease-related or autoimmune. And we tend not to need to do a CT scan at diagnosis, unless we're trying to work up a potential and working up whether a patient may have small lymphocytic lymphoma, which really refers to is the same disorder as CLL, but there are just less cells in the peripheral blood and more in the nodes and bone marrow. In terms of staging, there are 2 well-recognised staging systems for CLL that you'll see in any good textbook. We tend to speak about the Binet system, where patients which depends on the number of enlarged lymph gland areas, really picking out stage C patients who clearly require treatment, who have disease-related bone marrow failure with anemia and thrombocytopenia. Now, indications for treatment, as I've touched on, any evidence of bone marrow failure is a clearly agreed indication that we should be offering treatment. Also, whether we see any lymph nodes that are large, causing cosmetic or physical discomfort, or changing more rapidly, whether it's lymph nodes or organomegaly. We look at the lymphocyte doubling time and would start to be concerned if that is under 6 months, but obviously it's all a relative scale, and we'd be much more concerned about a lymphocyte count doubling from 200 to 400 than we would from 10 to 20. We also look at obviously continuing to be vigilant for autoimmune complications, many of which in the presence of stable CLL we can manage in the standard way with steroids, with immunosuppression. However, if we see an autoimmune hemolysis or ITP poorly responsive to steroids, then to control that we often need to treat the underlying cause of the immune dysregulation by treating the underlying CLL. We also look at the presence of B symptoms. As I mentioned earlier, we do need to, if there are significant B symptoms, we do need to have a good look to make sure we're not overlooking a higher grade transformation. And Richter's transformation is not something I have time to specifically talk about this evening. But really, when we're considering the indication for treatment, we try and add up all of these factors together to see whether the disease is progressing or causing problems. Now, taking a step back from CLL, moving back towards where this begins, it has been recognised now for at least around about 15 years that looking at in population studies, we can actually find the presence of a small clonal B cell population that has got the same immunophenotype as CLL in quite a lot of healthy individuals who are otherwise fit and well, and we see that much more frequently than we see CLL. And another, much as we tell the majority of patients with lymphoma that there's not an increased incidence in family members, we actually find with MBL that there's an increased incidence again over the background population that can be seen in first-degree family members of patients with CLL. And that has then obviously begged the question as to whether there might be any genetic inherited predisposition to developing MBL or potentially CLL. And there have been a number of studies looking into this, finding some polymorphisms or genetic, some particular changes in a number of genes that can predispose to the development of MBL or CLL. And I've referenced one publication there for anyone who would like to read a little more into that. But I want to stress that only a minority of patients with MBL will develop clinical CLL, and that percentage is between around 1% to 2% per year. Flipping it on its head, you could ask, we know that MBL can be a precursor condition, but flipping it on its head, the other question is whether CLL is always preceded by MBL. And we actually now have some data from a cancer screening study that was done in the States, looking at about 150,000 people, and annual blood samples were taken and cryopreserved. And on that, in that population, they identified 45 people who developed CLL, and they were able actually to then look at their retrospective stored blood samples. And in all but one of those patients, they did actually find on previous blood samples the presence of small CLL phenotype clones dating back a number of years prior to the development of CLL. So I suppose we all know that all cancers need to start with one cell that starts to go a bit rogue, and now we have a better handle on this. And in the clinic, we do know, given the fact that the progression rate of MBL is low, once we have monitored patients perhaps a bit more frequently in the first year, we can arrange blood counts and either in person or phone follow-up with patients with MBL, just around once per year, so an annual follow-up. So going back to the start to see how does CLL develop and how do we get to CLL cells? So much as with anything that goes wrong, whether it's say a clinical error or any other systems error, we know that often an error can result from often just not one thing going wrong, but often a few steps along the way, or checks or balances that get subverted, or checks that are missed. And that's much the same with CLL. We now know that we can trace back some of the genetic changes or oncogenic events to a relatively early B-cell precursor, and then we know that subsequent things have to happen along the way to lead to the condition, and the clinical condition we know is CLL. Now you can see in this diagram that that we're already splitting, we're seeing two development pathways there leading to some either unmutated or mutated CLL. We know that when we look at the gene expression of CLL cells from all patients with CLL, we know that CLL arises from a B cell that's encountered antigen at some point. But then we know when we look at the B cell receptor that around about half will show that their B cell receptor looks quite similar to a naive B cell, showing no evidence of this somatic hypermutation, so unmutated IGHV CLL, and then around half of patients will have a B cell receptor that has shown evidence of somatic hypermutation, suggesting that that B cell's gone through a germinal centre. So it's already hinting at, perhaps differing cells of origin where the final oncogenic events take place. And we'll talk a bit more about the biology and differences between these subgroups as we go through. So what goes wrong to lead to CLL? So a technique that's been used for a long time is that of FISH, or fluorescence in situ hybridization, to look at the chromosome level to see if there are any structural abnormalities. So there's a little picture of what a FISH assay looks like, and we know that one of the most common abnormalities is the loss of a region on chromosome 13q, which when present as a single event in CLL cells is present in just over 50%, and present on its own is associated with a relatively more indolent clinical course. We also see that commonly affected chromosomes are a loss of a region on chromosome 11q or chromosome 17p, and a little more on that later. But I'd like to just speak a little bit more about that deletion on 13q and how that relates to what happens in CLL cells. So over the last decade, it's been established that when a number of patients with CLL with loss of chromosome 13q were studied in more detail, the commonly deleted region actually contained and led to the loss of 2 microRNAs. So I'm not going to go into the full detail of microRNAs, but we know that they can regulate gene expression, and these particular 2 microRNAs that are commonly deleted in CLL cells with a 13q deletion normally and are now understood to regulate the expression of BCL2, so one of the major anti-apoptotic proteins. And the loss of these microRNAs leads to significant overexpression of BCL2 in CLL cells. And we know that that's one of the mechanisms that they use to evade programmed cell death. On the right, there's a nice timeline speaking about the identification of the BCL2 gene in the mid-80s, to then moving on to understanding the relationship between the microRNAs and BCL2, and then the development of venetoclax, which was approved in 2015 for treatment of CLL, and venetoclax being a BCL2 inhibitor. And as in the next week, you'll hear a lot about venetoclax, I thought I'd just put on a wee diagram just explaining how venetoclax works and what it does. Normally, as explained, there's the pro and anti-apoptotic proteins can bind to each other and neutralize each other. And then if there are any free proteins, pro-apoptotic proteins, they can then trigger the mitochondria to release all of their apoptosis-inducing stuff. What venetoclax does is it goes in and binds to all of this excess BCL2, so takes out the pro-survival BCL2, freeing up the proteins that will trigger the cancer cell to go into apoptosis. And it is a very effective, as we know, therapy causing really quite rapid cell death, and that then has led to how we introduce venetoclax to patients, monitoring for things like tumour lysis. So you'll hear a lot more about that next week. But I'll stick to speaking about biology. So other commonly common genetic changes we see in CLL cells. I mentioned deletion of chromosome 17p or chromosome 11q. And why might that be relevant? So we know that on chromosome 17p, the area that's lost encodes the p53 gene, and the area that's lost in the 11q encodes the ATM gene, and they both encode proteins that are very important in how cells respond to DNA damage and signaling to the cell that has sustained DNA damage to either go into cell cycle arrest and become inactive, or actually to trigger the cell to die off through apoptosis. So you can imagine that if these key kind of DNA sensing and regulator genes are lost, that can create a much more permissive environment for an abnormal mutated cell to survive. So we see p53 deletion in around about 7% of patients before first-line treatment, and we know that quite often when we see deletion of one allele or chromosome, that we see mutation of the p53 gene on the other allele. And we see chromosome 11q deletion in around 10 to 15% of cases, and this can increase as we see CLL coming back and relapsing. So it's other things that we know that can go wrong within CLL cells. We know that the B cell receptor in CLL, there are a few particular aspects about the B cell receptor and resultant signaling that are dysregulated in CLL cells. So I'd introduced at the beginning of the talk, I was speaking about VD and J genes that make up the B cell receptor. And one thing that's been recognized for a number of years is that the particular VD and J genes that are used in CLL cells are much more restricted than what we would be expecting by chance if CLL cells just had a completely random selection of B cell receptors using different VD and J genes. So we do see recurrent V genes cropping up much more commonly than we would expect by chance. And this is something that we call stereotypy, where we see that B cell receptors and CLL cells taken from different patients can frequently have near identical B cell receptors. And that led to the hypothesis that signaling or antigenic stimulation through the B cell receptor might be important in the development of clinical CLL, leading to work to then say, well, what could be the stimulus? What could be the antigen? Further work has found that many B cell receptors could recognize some self-antigens, particularly those seen on apoptotic cells, and whilst others could recognize parts of bacterial or viral antigens. But then what is actually going on? And I'd introduced that from the initial model of CLL, that two groups as to whether the B cell receptor on the CLL cells shows evidence of somatic hypermutation or not. And it's been recognized for about 25 years that whether there's mutation or not has quite an impact on prognosis and time to needing treatment. With those with an unmutated B cell receptor showing a much shorter time to progression and requiring treatment than those who have evidence of a mutated, somatic hypermutated B cell receptor. And then leading to saying, well, what's different? Is there any difference between the B cell receptor signaling in those groups? And it has been shown that those with an unmutated B cell receptor are much more responsive to signaling through the B cell receptor, and frequently the B cell receptor structure is much more reactive to many self-antigens, so the cell can really harness survival signals through that, whereas those that have a mutated IgHV, mutated B cell receptor, are much less responsive to B cell receptor signaling, and much more have a response much more akin to anergic or silenced B cells, and they tend to have a more clinical, a benign clinical course. So we know that B cell receptor signaling is important. And I'm not going to go through this in detail, but that obviously led to the B cell receptor signaling pathway becoming a key and logical therapeutic target. We know that downstream of the B cell receptor, a number of secondary signal transduction proteins are activated, leading to then transmitting the signals down to transcription factors, controlling what the cells then do. And all I would want to do at this point is point out where BTK fits into this, which we know is the target of BTK inhibitors, obviously, with the prototype ibrutinib, but obviously we have many more that are now coming through with acalabrutinib and zanubrutinib, both licensed in the UK. And however, we know that whilst B cell receptor signaling is very important, it's not all about the B cell receptor. And actually within the CLL microenvironment, when CLL cells go into a lymph node, they interact with a number of additional cells. And that includes the surrounding stromal cells, but also they secrete cytokines that attract supportive T cells, and also monocyte-derived, what we call nurse-like cells that really provide a number of pro-survival signals. And within the lymph nodes, we know this is where the proliferative fraction is, and we can see proliferation centres within the tissues. So we now know that CLL is a very dynamic condition, and that at any time there'll be a percentage of cells within the lymph node or bone marrow tissues interacting with a number of cells in the microenvironment, and there'll be a component of cells within the peripheral blood. And we do know that BTK inhibitors also inhibit the chemokine signaling, and that underlies why we see a rapid reduction in lymph node size and rise in white cell count when we use and introduce a BTK inhibitor. So the microenvironment is important. Now, I've been asked to speak about updates, so I'm wanting to move on to speaking about some of the newer molecular technologies we have, and they have really helped identify a number of the additional things that can go wrong within CLL cells that can help us to unpick the biological heterogeneity. So next generation sequencing really refers to more complete and faster and smart techniques to look at analysing cells for mutations, and it's picked out a number of key genes, and I'll just run through three quickly this evening. The first being Notch1, which we know is we can find Notch1 mutations in around 10% of CLL cases at diagnosis. And Notch1 encodes a transcription factor that normally regulates stages in normal B and T lymphocyte differentiation. And we see that the pathogenic mutations lead to an accumulation of the active form of Notch1. We can see a particular gene expression signature, and we know that it's frequently associated with unmutated IgHV and a more aggressive course, and slightly increased risk of high-grade transformation. Other genes to know about that can be frequently mutated are SF3B1, which can control the expression of a number of genes controlling cell cycle regulation or apoptosis. It's relatively uncommon, but can be seen in between 5 and 7% of cases at diagnosis. And another commonly mutated gene is BERK3, which again is a gene that's normally its normal function regulates apoptosis and also NF-kappa B signaling. And it's interesting that we rarely see a BERK3 mutation and a TP53 mutation in the same cell. They both seem to have a marked oncogenic role. Now, was asked to give some updates from ASH. So this is a slide from ASH last year, really just trying to put, how do we put this together and to look at whether CLL cells can have one, or how many mutations can we see of compound mutations, and what does that mean? There's a lot of discussion in the literature about karyotypic complexity, and this is a study that looked at almost 800 patients with untreated CLL, and looked at a panel of about 95 candidate genes by next generation sequencing, and they did pick up at least one mutation in over 90% of patient samples, with the expected genes coming out most commonly. But this does show on the right, the graph showing that the time to first treatment is generally shorter when we see more, if there are compound and a number of genetic mutations within the same cell. So that has been replicated by a number of groups looking at genetic complexity. We also have to bear in mind that not only do we see differences in genetic complexity between patients, that we know that, as with many other cancers, that we can see either clonal evolution or clonal diversity, that not all cells within one patient will be genetically the same. And this is a study, a very elegant study published by Anna Hsu, showing that over time and over the course of treatment, showing that different subpopulations or different mutations were acquired in just a percentage of cells. So we need to bear this in mind, particularly when we're looking at targeted therapies that might kill off a large percentage of the cells, but there may be cells that have a different genetic makeup and may be resistant. And we know that resistance mutations can be selected out in patients on long-term targeted therapies, for example. Now, coming up to the minute in terms of genetics, I have to put my hand up at this stage to say I'm not an expert in epigenetics, but I wanted to tell you something about this because this is new and changing our understanding, or further refining our understanding of CLL biology. So epigenetics does not refer to DNA mutations or structural, so it doesn't refer to gene mutation or loss. However, it does relate to the changes that can happen to DNA that affect how the DNA is read or used within a particular cell, much as, say, if we think of a piano that's got a set keyboard, the musical score will tell the pianist how to play the piano. The epigenetics machinery is kind of within the cell, what tells the cell how to read the DNA and which bits of the DNA to use. And there are a number of mechanisms whereby that happens through changes in methylation of the DNA or histones. And I'm not going to go through that in detail, but just to run through what we know about epigenetics in B cells. We know that B cells going through different stages of development have got a different epigenetic signature at each stage. And when we look at mature B cells, we can look back and see what's gone before. And studies that have looked at either unmutated or mutated CLL cells and looked at their genetic fingerprint find that unmutated CLL cells have an epigenetic footprint that looks most like a naive B cell, and mutated CLL cases most like looking like a memory B cell or more mature or post-terminal center B cell. So that wasn't big news, but what is more news and just published last year by the group referenced below is that epigenetic techniques have identified and picked up a third subgroup of CLL with more of an intermediate epigenetic phenotype that's not really closely matching a stage of normal differentiation. And within that group, it's frequently found a stereotyped B cell receptor. Generally, cases have a moderate amount of somatic hypermutation and are enriched for this BRC3 mutation that I mentioned earlier. So it's really starting to break apart and further define the heterogeneity and hopefully further refine our prognosis, and starting to tie together the potential cell of origin and also particular B cell receptors that are seen and particular genetic mutations that are seen. And we can see on the next slide where the dotted line where the graph is showing the time to first treatment. In addition to picking out these particular subgroups, they looked within each subgroup, as there is a technique called epiCMIT that I fully own up to not knowing terribly much about, but what it measures is it can do a look back. So it's very hard to study the proliferation of CLL cells that we take out of the body, but actually using this technique, we can look at the proliferation that's gone before, and they found that within each subgroup, they could identify cells with a higher proliferative history that could be prognostic of either a shorter or longer time to first treatment, obviously with a higher proliferative history correlating with generally a shorter time to progression and needing treatment. So currently we do have a CLL International Prognostic Index that can be used at an early stage of disease to try and look at the time and try to inform discussions with an individual patient as to what might the future hold. And that takes into account key factors such as the IGVH mutation status, presence or absence of TP53, as well as clinical features, age and beta-2 microglobulin. But I would hesitate to put out, and it's my opinion, that with the advances in our understanding of the molecular biology, that may well add to and further refine these prognostic scoring systems as we go forward. So I'd started to talk about the fact that we nowadays pick up the majority of our patients incidentally at an early stage. And I think it's quite useful to look at the prognostic scoring system, as it can pick out and help inform discussions and diagnosis to identify which patients may have a very low risk score and patients with stage A with a low risk score have only an 8% chance of requiring treatment at 5 years, and up to a third will never require therapy within their lifetimes. But on the flip side of that, what about patients that the prognostic scores might mark out to have a higher risk of progression? What do we do? And one question is, does any early intervention help these patients? Now, historical trials looking at early chemotherapy have not to date shown any benefit of early treatment of patients with early stage A stable disease. But as we've moved to targeted therapies, that begs the question as to whether any of these therapies may have benefit for patients that we think may be at a higher risk of progression. And I'd like to just spend a little bit of time speaking about a trial that has been presented last year with final results, the CLL-12 trial, where patients with stage A disease were included, and low risk patients were managed with standard active surveillance. Higher risk patients were randomized to either receiving early ibrutinib or placebo. So it's a fully randomized placebo-controlled trial. And although this trial did show that ibrutinib could delay progression, at 5 years there was absolutely no difference in survival of each group. And obviously each targeted therapy, all of the therapies we have do come along with potential side effects. So really, to date, even with targeted therapies, we don't have any evidence that early treatment will improve longer term survival. So I think that gives confidence and credence to what we are currently doing in the clinic. So speaking about active surveillance, or what we have called watch and wait, or perhaps we should really speak about active surveillance. What does it involve? How often do we need to do it? And generally, when I meet a new patient in clinic, we'll always, in first year, see our patients at least every 3 months. And then we're looking at the blood count, we're looking at the lymphocyte doubling time, we're looking at the hemoglobin, the platelet count, we're assessing for any change in nodal size, obviously looking for the development of any autoimmune complications or infections. And it's important to say, what I've not touched on so far, is that the immune system obviously has a very important job in preventing and identifying and preventing development of malignancy. And we know that the immunosuppression in CLL that can accompany CLL, that second malignancies, particularly skin malignancies, can be that much more common. So it's important that we do bear that in mind and are actively looking and investigating any symptoms of concern and encouraging patients to keep up to date with all screening programs. We're also asking patients about any B symptoms, where fatigue is something often reported, and asking any change in energy levels, any night sweats, or looking for weight loss. And also when we are now using our targeted therapies, we're also looking at comorbidities and any new medicines that might have a bearing on treatments that we may need, the treatment that we may recommend if the CLL progresses in future. So it's a really active process over time, and we do need to fit the right strategy to the right patient. As many people with stable CLL, we just need to see once or twice a year. And again, that could either be in the clinic, and for some people with stable CLL, that could be by a telephone call with a nurse specialist. But however we do it, it's a very active process. Also, to keep people living well with CLL, we need to be very proactive at preventing infection. And to do that, it's important to do that at an early stage when we are more likely to see a robust immune responses to vaccinations. And the vaccination schedule recommended for patients with CLL is slightly different to others. For example, with pneumococcal vaccination, it's not just Pneumovax, but recommended that patients receive Prevnar, followed at least 2 months later by Pneumovax. At the start of the COVID pandemic, it was clearly shown that patients with CLL benefited from an initial three-dose primary induction course, and then keeping up to date with boosters. Nowadays, at this stage, most of us have all had many boosters, but it's just important to say, keep up to date with recommended boosters and seasonal flu, not just for our patients, but also other household members. But one thing that is new, and perhaps and is certainly being rolled out where I work, is that we've spent a lot of time telling our patients never to receive the shingles vaccine, as it used to just be Zostavax, a live vaccine. However, over the last couple of years, we've had access to the recombinant shingles vaccine, Shingrix, which was initially just approved for those patients aged 70 to 79 who would otherwise receive Zostavax, but now it's been approved for patients with immunosuppression aged over 50, and that is certainly being rolled out where I work at the moment, and I would anticipate throughout the UK. If that is difficult to remember, one thing that I would like to promote is the CLL vaccine passport that has been produced by the CLL Forum and CLL Support. And I have to say, I find it by Googling it. It is on the CLL Support website. And I often give this out to patients at the same time as written information about CLL. And it has a clear table to keep a note of vaccines received and which ones to receive. We also do want to stress to our patients that antiviral therapy remains available for confirmed COVID-19, and we also treat flu. Sometimes with recurrent infections, we can use prophylactic antibiotics, but I've usually often included or discussed my patients with my respiratory colleagues by this point. Sometimes we can also use intravenous immunoglobulin for patients still struggling with recurrent infections who don't respond well to vaccination. And my last point is, yes, I know it's difficult in the depths of winter to remember summer, but when the sun does come out, it's really important to protect the skin. Okay, and so I will wrap up now by really concluding that we've spoken about CLL as a leukemia of mature B lymphocytes, and we've shown that we now understand the biology a goodly bit more. As my colleagues, I'm sure, in next week will speak about, we see the outlook is continuing to improve with our newer therapies with each successive decade. The knowledge of disease biology has already transformed our therapy from chemotherapy to targeted agents. and certainly understanding the biology and disruptions of the genome will really help us identify future treatments. But given the advances that have already been made within the last 50 years and the translation into smarter therapies, I think we have many reasons to be optimistic going forward that we are working towards. What we ideally want to do is to cure this disorder. So I will wrap up there and hand back to our chairs.
Thank you, Alison. Thank you. That was an absolutely marvellous tour de force of the diagnosis, early workup, and how we manage early stage CLL patients. So we've already got a number of questions coming in on the Q&A, so do post them. They're coming in around MBL, a little bit on therapeutics and biology, which we'll return to. This evening, we've made a specific decision. We're not going to get ourselves drawn into treatment A versus treatment B in different circumstances. But I think I'm going to kick off. You've covered so many areas really clearly there, Alison. But I guess one thing that always comes up in clinic is how much do we work up that new presentation, low risk, early stage CLL? Because there are obviously two sides of a spectrum from saying, look, you've got a lymphocyte count of 10, 11, you're basically quite well. We should do very little. To the other side of doing a full genomic profile and everything. And I hear the arguments about structuring clinics or letting them go and sort of trying to personalize risk, which I slightly struggle with because risk is quite a prognostic population-based tool rather than an individual predictive tool. But what are your views? What do you do in Glasgow for your patients?
Yeah, I have to say, where I work, we've perhaps we certainly have increased access to checking, say, IGHV mutation status. I certainly don't check FISH looking at P53 at all cases at diagnosis. It doesn't. I think with every test, we've got to think, what do we do with that information? Will it change? And I think it does have to be, before any testing is done, to discuss with an individual patient what they would wish to know. I certainly, and please don't be too upset with me, Renata, I don't test absolutely every CLL patient for IGHV mutation at diagnosis, as it does say in the BSH guideline. So I think it does come down to, what are you going to do with that information? Is it going to influence your choice? And I'm not in any way ageist, but I think it might be, and if there are other clinical or whether it's comorbidities or medications that would clearly influence my treatment choice, I may not check IGHV mutation when I'm treating perhaps an older individual where there's a clear other factors that would influence my treatment choice. I think I certainly do, and over the last few years, over the last couple of years, have certainly moved towards, if I meet a patient who I think is moving towards treatment, who I hope to look after for many decades into the future, and I'm trying to look at what the longer term treatment course would be, certainly assessing IGHV mutation, how we use that to decide treatments and whether certain treatments are better.
That's for a different session.
Next week. That's a different session. And certainly in terms of going to town of checking FISH at diagnosis, in our Scottish CMG, we have updated that to say that we would tend not to necessarily check an early CLL patient with a very low lymphocyte count, as we know that can change over time, and there's no change in treatment if we know that information at the outset. I would obviously have a discussion with the patient, and if a patient would be very, very keen to know that information, then it could. I'm
encouraged. Sorry, I'm going to keep things moving. So I've got lots of questions. Yeah, I'm encouraged to hear that. Renata, let me just bring you on that point. I think so. I can't help but do a bit of an actuarial test on a patient. If they're 75 with comorbidities and a lymphocyte count of 15, doing an IGHV mutational profile up front, you need to spare your lab from doing too much work. Renata, defend a different perspective. Are you doing more than that in Bournemouth?
Yes, I do, because I can. I've got the lab locally who can do it. So for me, it's quite an easy test. But yes, you're right. I can hear what you're saying. Yeah, for elderly, when obviously we discussion on treatment, we'll be obviously doing next week. But if you've got young person, and by young person in Bournemouth, young is 70, 80, that's young. Because I do have patients in clinic who are on the wrong side of 90, quite a lot of them, and they're very, very fit.
They would argue the right side of 90.
Yes, the right
They
side.
made it. They're survivors.
That's very true. So, and don't forget, I inherited my clinic from Professor David Ossier, and there are some patients who I've still got them in clinic, and I'm trying desperately to discharge them, who are in follow-up for over 20 years, and they still have not progressed. And because they like the security of hematology clinic, some of them, it's very difficult to discharge them. But I found that if I've got a person in their 50s, and I do, even if lymphocytes of 10, I do IgHV, because at least if it's mutated, um, to say to a patient, I'm going to discharge you to GP, it's like lifting this cloud. It's just, oh, what do you mean? I don't need to be in hematology clinic? So of course, when I'm
So
discharging, I give clear instruction when to send them back. But I think for patient,
but
it's
we,
such a positive thing.
we'll come on to those early stage patients because there are very different views around the country. Because I could argue, well, even if they're unmutated, if they're well with the lymphocyte count of 10, can't you send them back? I think sometimes we can be overly influenced, as I say, by population groups, and even a poor risk CLL. If we looked at those complex genetic curves with the highest risk, half of them have still not been treated at 5 years. So I think there's so much psychology at play. So Renata, I'm going to go to you on the last lab question before I come to the MBL questions. So we can, of course, get so much sequencing data, and Alison really expressed that and showed it very elegantly. Everything from Notch to Berk3, all the different things. And we wrestle with what to do with that information. So I guess the most challenging is an early stage A, then treatment. Are we actually influenced by these beyond TP53, Renata? Can you give me any time in your clinical practice where you are influenced by them at the moment?
I've got to say the ASH 2023, the ASH just gone, completely confused me, because of course before ASH 2023, before the flare data, before what we all have seen, my default was all mutated patients should be offered VO.
Oh, no, I was talking about the
But
mutations. But let's not get into that
oh,
because
sorry,
that's going to take a
that's
whole
obviously next year.
session
Yeah,
next
yeah,
week.
next to Monday. Yeah.
No, it's just the extra mutated genes like a Notch
Oh, I see.
mutation
Sorry.
or a BRCA3 mutation.
Yeah,
Can you see a scenario when you actually use that in clinical practice?
I think not in next 5-10 years, no, because we don't. I mean, the only thing we can't really uh, adjust our treatment at the moment really well. We know that, for instance, people with Notch don't. That's all CLL-A data. They don't respond very well to antibody. But are we gonna really deny antibody to those patients? So no. I've got to say, at the moment, no. The P53, obviously, it's the most powerful, and coming back over and over, that's the most powerful prognostic marker. And same IgHV. But the Berg, Notch, and SF3B, probably not just.
ATM?
Yeah,
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 probably not
80.
yet.
Well, actually, ATM been shown, obviously, with continuous treatment as not adverse prognostic factor if somebody is on maintenance BTKI type of therapy. So kind of
Yeah.
ATM kind of lost, thanks to our current options for treatment.
I
Yeah,
think
but
it.
it's harder to notice. So, Alison, yeah. So,
Oh no,
what are
I was
your
going to
views
say,
on this?
I think as Renata says, I think it's going to be a long time, but I think we've identified clearly the targets of BCL2 and BTK as what are almost like the low-hanging fruits, and the universal things that are dysregulated in CLL cells. But I think the next 5 to 10 years of science is going to be looking at not just the NOT1 mutation in the BRCA, but looking at all of the things that are different and could be the next targets for targeted therapies. But that's obviously going to take a long time. Well, not hopefully too long, but a number of years for that, what's coming out of, say, the epigenetics and NGS to then translate to identifying what the next targets that we could use in combination or to eradicate MRD could be.
It's an interesting comment on the biotech development of treatment for CLL and why, when you take a step back, do we wonder there's so much pushing still on BTK? Because, of course, the joy of BTK is we've got large data sets which remind us how minimal the toxicity is. And as some of the UK community know, I've spoken on this topic before, that toxicity is what kills drugs early on in the development, the biotech going to phase 1, et cetera, et cetera. And I think BTK keeps showing that it's a really clean target. And it is no surprise to me that we're having the non-covalence, and then we're going to go through the BTK degraders, et cetera, et cetera. Now, because I know we're pushed for time, because we've decided we're taking 10 minutes from the next session. So this is continuing to roll for a bit longer because we've got questions about MBL. And I do want to just answer those, and also a couple of questions for get a patient perspective on workup investigations for clinical trials. I thought of an interesting question. So MBL, now your Scottish colleague Gavin Preston up in Aberdeen from memory, has put in some good questions about MBL and arbitrary cutoff. And if you say, and I definitely get this point, that a high count MBL and a low count CLL, they're basically on a continuum, and we've sort of arbitrarily drawn 5 as a line in the sand. If you're following up these early stage CLLs, which I do want to just explore secondarily, but if you're following up, shouldn't you be following up a high count MBL just like you follow up a low count CLL?
In my clinic, we do much the same. And actually for our patients with either a high count MBL or an early CLL, I have to say we don't tend to discharge our patients back to GP care looking for re-referral back, but we do have a clinical nurse specialist who has a nurse-led clinic and will monitor, usually by annual telephone reviews. The bloods are done a week or 2 beforehand with a phone call, and he will look at. So essentially, I do agree that having a cutoff of 5, I think you've got to have cutoff somewhere to have clear diagnostic criteria for whether it's trials or just general organising what we say in life. But it's completely arbitrary, and what we do with somebody with a clonal B cell population of 4.8 and somebody with a clonal B cell population of 6.2 is exactly the same. So yes, I agree, it's arbitrary. So we just need to be using our clinical nons to think of making sure that both of those populations of people know what to look out for, what to let us know, and it's exactly the same advice.
There you go, Gavin.
As
so you've
to
got
what
that
we
answer.
do about vaccination and so on, that's a very good question, because I don't tend to with MBL patients. I wouldn't, but then that's now time I have not.
I think they have the same markers in terms of, if you look at some of the data sets suggesting they probably are equally prone to immune failure and infections and things. But so I'm just that final, so the early stage CLLs, I'm going to bring Renata in here. So I must say, in Cambridge, an hour east of England, we try hard not to keep this type of patient attached to a clinic. And as much because I think logistics and straying into that quite challenging area of providing primary care advice, but I guess your nurses are quite trained in how they deliver. Because my always worry is, say a patient reports a cough to your nurse, who makes the decision to send them for a chest X-ray, and who follows up that advice, or do your nurses send them back to their GP for that, or it's sort of working out that legal line of responsibility? So actually, I started saying to Renata, and I went back to Alison there. Sorry.
Yes, sorry, I was thinking that might come back to me. So I guess we have we would if generally for our patients we're always contactable, and in the majority of cases for our patients who are not on treatment, we may advise to contact the GP for a relatively uncomplicated respiratory infection. But we would then always stress that if there are non-resolving infections, then we might need to become more involved. But that's
So
a very
your
good point.
nurses they sort of take on quite a bit of that primary care. Then your patients might well ring them before ringing their GP for something, or
the reporting of managing to get a GP appointment, many of our patients will phone us before phoning their GP. And I think
so you're stoking my fears of creating another GP net. Renata, can I bring you on that comment? Sorry there.
So I have, because of Professor Terry Hamblin, who obviously was working in Bournemouth, and David Ossier, we've got a tissue bank. So yes, we used to historically take all the MBLs and bank them. Obviously, recently we had Anna Shu study. So again, there was a reason to get all the MBL and sign them up for study. But I've got to say now that study stopped recruiting, I'll probably see them once and refer them back to the GP, because as you say, there is I think it's a huge burden to be in hematology clinic. Not only for the patient kind of feels that there is something seriously wrong, also the problem is all our colleagues. And I feel like if I discharge them, I'm saying that condition will not cause any other problems, because of course, I mean, we all finding that chest pain, oh well, it's caused by MBL. Well, what do you expect, because you've got an MBL? And I think if I discharge them, that suddenly it's ownership back to the GP, think as a normal person, not somebody with MBL. So I think that the fact, I mean, that's, I think, and that's what I tend to used to do. If somebody did not want to sign up to Anna's Oxplode, I would discharge them to clinic, because at least makes it clear, because then the secondary care will not blame any odd symptom on MBL. It just makes the division clear.
So Renata, that's good. So I'm going to bring in Lelia and John. I did say that we'd be bringing them in the second half, but because I want to ask them this other question about trials and investigations for trials that occurred to me. So Lelia, we don't have that much longer, but the concept of being discharged back to primary care as a patient with early stage CLL, Lelia and John. So Lelia first, would you have a view on that? Do you find that acceptable? Do you find it frightening? Do you find it encouraging?
I mean, there's huge variation, I'm sure, in that some people, as Renata's described it, finding it really reassuring to go to a haematology clinic. Other people are, you know, particularly if you've got good general practice locally and a good relationship with your GP, I'm sure there's lots of people that would find it much more convenient. The big downside of going to haematology for me is the car parking. I can walk to my general practice, but I need I get post-traumatic stress disorder just parking at my hospital. It's huge variation. I don't think there's one size fits all, but I think I heard Piers Patton say that he tries to demedicalize. And I think that's the key concept, is actually these are helping people understand what their, as you say, their personal level of risk rather than a population based, and what they need to do if they're anxious about one of their results. Again, a lot of people like to find their own results, to be told their own results, rather than just have somebody tell them that it was okay. And a lot of general practices will say, don't call it, you know, we'll call you if there's a problem. So explaining to people how they can I think I'm warbling a bit here, but I think the key thing is to find out what works for that individual. And if they've got anxieties about coming to the clinic, maybe try to address what some of those are. Because I absolutely understand that it's more sensible in many ways for them to be managed in primary care.
So I think we'll have to move on from this topic. It's very variable around the country, variable between patients. And I think, Lelia, you did highlight a couple of things. But my last question before we move on to the second session, I was in a trials meeting today, which we're setting up. And as always, I was told that if the patient's in a CR, we then confirm it with a bone marrow biopsy. And I said slightly glibly to the trials coordinator, so we reward the successful patient with a bone marrow biopsy. Is that going to put them off joining the clinic? And Alison was reminding very nicely that we actually do very few bone marrow biopsies now in CLL. It's quite different from how it used to be 15, 20 years ago. As a patient, Leila, or John, if he's there online, would having bone marrow biopsies or lymph node biopsies put you off going into a clinical study? Is that a type of thing that would be a decision point for you, or we just say it's the way it is?
I took part in the Clarity trial, and I've lost count of the number of bone marrow biopsies I've had, because that was an early phase study. Again, I think it's variable. Some people who, if you're needle phobic, you're not going to want to do it. Bone marrows would put you off.
Yeah.
And I think also, you don't assume that people understand what a bone marrow biopsy is. It's very easy to sign the form saying, I'll do it. But if you haven't clearly understood, then you might actually sign on the dotted line, but then balk when it comes to it. And my personal experience actually is that if you're having bone marrows done by nurses who do them all the time and are well trained,
you might be less painful.
To be honest, I had one last week and I hardly noticed she was doing it.
Oh, Leila, your nurse is going to be inundated with requests.
Yeah, and the first one I had many years ago by a stressed junior doctor who was bleeped to come and do it was a horrible experience.
Oh. I think we should move on. You're going to traumatize any patients. Now, John, you come online. So, sorry, John, you're here now. 2 minutes. Your thoughts on those last points, and then we are going to move on. Apologies for any questions unanswered.
Okay, the earlier question, and it depends on the context. If as a patient we feel we're being looked after properly, rather than somebody washing their hands of us onto another department or another entity, like back into primary care, then that tells us a lot. If we've been looked after, then it's absolutely fine that we should be returned back into primary care. Bone marrow, we could talk for ages on this. I go to a Maggie's group, and it is flavor of the month every month. And I suppose I shouldn't say, but I will. Some of the clinicians have been scored, but no names, no pactoral. I think we should move to the next session, George, Renata.
Right. So thanking Alison hugely. That was a brilliant talk and wonderful discussion, Alison. Thank you. But please, Alison, stay around because Renata will be drawing on our expertise after the next session. And I hand over to you, Renata. Thank you.